Hello, Assalamu alaikum, good morning, good afternoon, and good evening, according to the time zone of all the students who have joined in and who are listening to me currently. So, this is me, your mentor, Dr. Asma Ali, and today I am going to start one of the very important module that is very important in term of your exam, in term of like theory and also the OSCE and the Viva. And the module is maternal medicine module. This module is never skipped in your any exam, whether you are giving FCPS exam, whether you are giving the MRCG exam. So 100% SBAs, EMQs, MCQs are coming from this module. So it is very extensive, it is very important. So I have brought a list for you, which we will be, inshallah, we are going to start that slowly, bit by bit. And I like the screen because you can see here, this is the this is the transport. This is the bus. We have started maternal medicine module bus, and we are going to finish it till we reached somewhere here. Okay, so I like this colorful screen and I brought it for you because the things are sometimes seems very volatile, dry, and so I thought that I should bring something colorful and so that you can enjoy the reading, listening. So let's start it with the name of Allah. And in the maternal medicine module, we have included topics which are now in front of you. I am bringing them. So this is a list which we will be inshallah studying. The first is the most important, is the hypertension in pregnancy. This is very important. Next is diabetes mellitus in pregnancy, and epilepsy, bleeding disorder, sickle cell disease, thalassemia, VTE, obstetric cholestasis, anemia in pregnancy, thyroid problems in pregnancy, asthma in pregnancy, and thrombocytopenia in pregnancy. So you can see that each one of the topic here is very important, and you cannot skip, even you cannot can forgive any topic among these alls. Each one of these topic is very important, and each one of these topic harbored a lot of NMQs and SPAs that can come in your exam, whether you are giving FCPS, MRCOG, your intermediate module of FCPS. So this whole maternal medicine module is important. So I started with this one because many students found it a little bit difficult. Obviously it's lengthy, no doubt about it. But if you continue with me this module, then the things are going to be easy for you. Inshallah, I will try my best to make all the things and the queries, difficulties, the hurdles for you little bit easy, inshallah. Okay, so we are starting today with the important topic which you cannot skip in your exam without answering in your theory, without answering, without explaining this topic in your MCQs, OSCE, talks, Viva. You cannot pass any exam of your education. Okay, so diabetes in pregnancy is very important, and we are going to study it from the NICE guideline 2022 updated guideline, and this topic contains preconception planning. This preconception planning is important for your talks because now you can get it like patient has came to you for the pre-pregnancy counseling. She's diabetes, or she's concerned of having diabetes in pregnancy. So and the effects of diabetes in pregnancy upon her and upon her baby. So you are going to counsel that patient. And then the gestational diabetes, I will today in this lecture I am going to teach you the preconception counseling. As I told you that we are moving with slide by slide, bit by bit, important topics. And the next I will be inshallah teaching you the gestational diabetes, and you know very well it's very important, very important. And the antenatal care of diabetic patient in pregnancy, and the postnatal care of diabetic patient afterwards of delivery. So today is the preconception planning, and I am also highlighting the important SBAs, EMQs in this topic as well. So you should be very careful, and you should also note that things, because these are important MCQs for your exam. Okay, so I hope you have prepared your some writing material, notepads. You can note them, and they are going to help you in your exam for quick revision. Okay, so as I have written here is that this is very important, your talk station. Also it can come, many points can come as SPAs and EMQs. So the first thing, if you contact a patient, if a patient has came to you in your preconception clinic, and she is asking about some information, so what information you are going to give to the patient about the risk of diabetes, which are for the mother and the baby? So first you have to give some sort of information about the outcome and the risk for the mother and the baby. So what you are going to tell her, you are going to explain to the woman with diabetes who are planning a pregnancy that if they are going to have a good blood glucose control before conception and throughout their pregnancy, this is going to reduce the risk of miscarriage, congenital malformation, stillbirth, and neonatal death. So what this is going to reduce? As you can see here, it is written that the risk can be reduced, but the risk is not totally eliminated. So this thing should be emphasized, that if patient is serious about her health, her blood glucose level, the things are going to reduce. But unfortunately, the things cannot be totally eliminated. Okay? So my dear students, you have to note down this point. The next one, that you should encourage her about the role of diet, body weight, and exercise. That extremes of body weights can have detrimental effect on the patient and the baby outcome, and the exercise is obviously has a very good effect on the patient and her pregnancy. Then you can also tell her that the risk of hypoglycemia and impaired awareness of hypoglycemia during pregnancy, that if patient is not aware that how the hypoglycemia can occur, what are the symptoms of hypoglycemia, what are the signs of it, and she cannot aware that I am going to have a hypoglycemia, I should take some help, I should take some sweet candies, when she think that she is going into hypoglycemia. And if she is not aware of this situation, then this can have a very bad effect on her pregnancy at that time. Another important point, that initially when many patients have got nausea, vomiting of pregnancy, sometimes hyperemesis gravidarum as well. So the nausea and vomiting in pregnancy can affect her blood glucose control. So these points you should highlight to the patient who have came to you, who is sitting in front of you in your exam, in your clinic. Okay? The next one, that increased risk of having a baby who is large for gestational age. Okay, LGA. So you are going to tell her about LGA, that there is increased likelihood that if the blood glucose is not controlled, she can have large for gestational age baby, and this can increase the likelihood of birth trauma, induction of labor, instrumental delivery, and the C-section delivery. Okay, so these are the side effects, these are the risks for the patient if she is having large for gestational age baby. Okay, then you need to emphasize on the need for diabetic retinopathy assessment before and during pregnancy. If the patient is already diabetic, I am talking about the patient is already diabetic, then they have to have the assessment for diabetic retinopathy. And this diabetic retinopathy assessment is done before as well as during the pregnancy. So the next important point is that you have to explain the need for diabetic nephropathy assessment, which is done before pregnancy. As you can see, you can notice that diabetic retinopathy assessment is done at two occasions, that is before pregnancy and that is during pregnancy as well. But nephropathy assessment is done only during only before pregnancy. So this question can be asked from you, that whether I need to do it before pregnancy or I should do during the pregnancy as well. So you can give the answer according to the what is written in your guideline. Okay. So again, in what you should tell her about the baby as well. Okay, the importance of maternal blood glucose control during labor and the birth, and the need for early feeding of the baby in order to reduce the risk of neonatal hypoglycemia. You have to counsel her that the baby is at risk of neonatal hypoglycemia, so she need early feeding of the baby as soon as possible, and ideally within half an hour of delivery of the baby, she should feed her baby the first feed of herself. Okay. So the next, what you can tell her about the outcome of the baby, that possibility of that the baby may have health problems in the first 28 days, and she may need admitting her baby to the neonatal unit. As you can imagine that the baby could have respiratory distress syndrome and the hypoglycemia issues, the jaundice issues, and many more. Okay. So because of these problems, baby can have multiple time admission, baby can have multiple time reviews from the NICU specialist. And what you can tell her in terms of long-term morbidity of the diabetes on the baby later on in the life, you can tell her that the risk of the baby developing obesity, diabetes, and other health problems in the later life, baby could have these problems. Okay, so initially what we said, that we just give her the outline, that the diet and the body weight exercise. We tell her something about the hypoglycemia and nausea vomiting in pregnancy. We tell her that if the things are not in control, she can have a large for gestational age baby. And we emphasize on diabetic retinopathy, nephropathy. We also emphasize during the pre-pregnancy counseling about the baby early feeding importance and some health problems which can baby have in the first 28 days, and afterwards later on in the life the baby could have some problems. Okay, so why we are studying this topic, why we are reading this, because I just mentioned that this is obviously one of your important talk station, but we have to emphasize on the importance of planning for pregnancy, because if patient is planning it well, then the complications of diabetes, the risk of diabetes are very much less. Okay, so we have to emphasize on the importance of planning for pregnancy as a part of diabetes education. We have to advise women with diabetes that they can use oral contraceptive or any sort of contraception which suits her according to her preferences, according to her risk factors. If she has some risk factors, she can use those, any sort of contraception according to FSH. So she can use oral contraceptive, and she should use contraception until they have good blood glucose control. And how the blood glucose level is assessed by? It is by HbA1c. So this can be asked from you, that how you is going to tell her that we are going to assess your blood glucose level. You are going to tell her that we are monitoring, we are assessing your blood glucose with the help of HbA1c. So this is your important single best answer. And in how much frequency we are going to assess HbA1c? Either it is monthly or it is 3 monthly. So you can have query in your mind that what you are going to tell her, monthly or 3 monthly. So the answer is coming to you in a short while. Meanwhile, you can guess it in your mind that if the patient is came to you for pre-pregnancy counseling, how many times, in how frequently you're going to have her HbA1c. So I'm going to tell the answer in just a minute, in a short while. So the target, you have to tell her that the blood glucose target, glucose monitoring, and the medicine for treating diabetes and medicine for complications of diabetes will need to be reviewed before and during pregnancy. Okay, and the extra time and effort is also needed to manage the diabetes during pregnancy. Means she could have multiple time contacts, frequent contacts with the healthcare professional, and you have to provide information about the local arrangement for support, including the emergency contact numbers. If she can develop sometimes some complications, some risk, she's worried about her blood glucose level, she's worried about her fetus, so you should provide some emergency contact numbers, that to whom, to which healthcare professional she should contact in case of emergency as well. Okay, so the important thing is that if patient asks that how the diet and the dietary supplements can help me in controlling my sugar and how I should manage my body weight, or if you think that she is obese, she's overweight, what are you going to counsel her? So you have to offer individualized dietary advice to women with diabetes, that it depends how the patient physical condition is going on. So according to that, you are going to advise the dietary counseling. And the next important thing is that for women with diabetes who are planning a pregnancy and who have a BMI above 27 kg per meter square, you are going to offer to lose weight. And my dear student, this is your important single best answer, that above, if patient came to you in pre-pregnancy counseling and her BMI is above what level or at which level, that you're going to first offer her, you're going to first counsel her about losing weight, and that above 27 kg per meter square. What is 27 kg per meter square? You are advising the patient to lose weight. So this can be your SBA. Okay, next you're going to offer her that the woman with diabetes who are planning pregnancy, she should take folic acid. How much dose? 5 milligram. Please remember, this is 5 milligram, and this is one of the most important question of your exam, that she should take 5 milligram per day until 12 weeks. Okay, like as soon as she started thinking about having a pregnancy, she is planning to have a pregnancy, she should start taking folic acid ideally 1 month, 3 months before the pregnancy, and she should continue until it 12 weeks of gestation. Why? Because this is going to reduce the risk of having a baby with neural tube defect. And again, this is your important SBA, single best answer. So the important points you should note down in your notebooks, because they are your MCQs, SBAs, or can come in the form of EMQs as well. So what I was talking about, that blood glucose and ketones before pregnancy, how the patient is going to monitor them. You have to offer up to monthly measurement of HbA1c level for the woman with diabetes. So I told you just a few minutes back that how much frequently you are going to measure the HbA1c level. So the answer is monthly, and this is your important question. When you study the book Konji, the Konji has also given the question on measurement of HbA1c level, and the answer is monthly when patient came to you in pre-pregnancy counseling section. Okay, so you can offer blood glucose meters for self-monitoring to women with diabetes. Like, we can educate the patient that she can have self-monitoring at home by having a blood glucose meters. And if a woman with diabetes who is planning a pregnancy need to intensify blood glucose lowering therapy, she should be advised to monitor her blood glucose more oftenly to include the fasting level and a mixture of pre-meal and post-meal levels. Okay, see, she can measure her blood glucose level at home by measuring the fasting level and a mixture of, sometimes she can have pre-meal and sometimes she can have post-meal levels, and this can help her that my sugar levels are going in optimal level, in the normal levels, or they are somewhat above the normal level and I should intensify my blood glucose lowering therapy. So another important thing, that you can offer blood ketone testing strips. You have to remember the blood, like what? Not urine. This is blood ketone testing strips and a meter to women with type 1 diabetes. So this is important, that to which candidate, to which patient you are going to offer these strips and meter? The woman who is having a type 1 diabetes, who are planning a pregnancy, and you have to advise them to test for ketonemia if they become hyperglycemic or if they are feeling unwell. So this is your important exam, especially the MRCOG2 exam question, that what you are going to give to the patient. For measuring ketonemia, we are not giving her any advice, any strip for measuring urine ketones. We are going to give her strips and meter that can measure blood ketones. Okay, so please students, note down this important point. So the very important next slide is the target blood glucose and the HbA1c levels before pregnancy. This is important SPA as well as your EMQ. You have to advise women with type 1 diabetes who are planning a pregnancy to aim for the normal capillary plasma glucose target ranges. So what are the target ranges? That the fasting should be the fasting plasma glucose level of 5 to 7 on waking. When she get up in the morning or whatever the time is, the fasting should be between the 5 to 7 millimole per liter. And a plasma glucose level before meals, please note down, this is before meals at other times of the day, that what are those ranges? That is 4 to 7. So you can see this thing is also very easy, that it is 5 to 7 and this is 4 to 7. So you can give target range to the patient as well in term of blood glucose, that fasting should be 5 to 7 millimole per liter, and the before meal any other time of the day, the target blood glucose level should be between 4 to 7. So it is easy, 5, 7, 4, 7. Okay dear students. The next one about HbA1c level. So you have to advise women with diabetes who are planning a pregnancy to aim to keep their HbA1c level below. Please note down the word below. It is not at 48, it is below 48, like below 6.5. Okay? So the word is below 6.5%, or it is below 48, which is below 48 millimole. Target HbA1c level should be below 6.5% or below 48 millimole per mole. Okay, and this is if this is achievable without causing problematic hypoglycemia. So as you can see, it is important SBA, your single best answer. And you have to reassure women that any reduction in HbA1c level toward the target is likely to reduce what? The congenital malformation in the baby. Like, you have to give some good reassuring point to the patient as well, that if you are going to concentrate on targeting your HbA1c level below the normal, then this is going to give you good result in terms of reducing the risk of congenital malformations. Okay, so we are not just overburdening the patient that please complete the target. We are giving her some good points as well. Okay, so the next important point, that at what HbA1c level you are going to strongly stop that woman from conception, that she should not get pregnant. So what is that level? That HbA1c level above. So please wrote down that this is above. The above 86 or it is 10%. Please, these are important points. Note below and above point. That above 86 millimole per mole or above 10% HbA1c level, you are going to strongly advise not to get pregnant until their HbA1c level is lower, because as the risk is increasing for the congenital malformation as HbA1c level goes high and high. Okay, so please note down the important points in these slides. Next, obviously the patient, if she is diabetic, non-diabetic, she must be taking some medicines. So safety of the medicine, we have to check for the diabetic patient before and during pregnancy. So you have to counsel her that she can use metformin as an adjunct or alternative to insulin. If she is already taking insulin and with those insulin her blood sugar is little bit above, or she's not satisfied, she can add metformin, or if she want alternative to insulin, she can start metformin because this is safe drug. And look, it is written here that stop all other oral blood glucose lowering agent before pregnancy. Okay, so what about insulin? It is written that rapid acting insulin analogs, for example Aspart and Lispro, they does not show an adverse effect on the pregnancy or the health of the baby. So we can use rapid acting insulin in the form of Aspart and Lispro very safely. Okay, so next, that if we are managing the patient blood glucose level in collaboration with the dietitian and the endocrinologist, and her blood glucose level is not very much good with the rapid acting insulin and we want to add long acting insulin, or if we are going to start the patient management with long acting insulin, so what should be the first choice? The first choice we can have is isoflurane insulin, that is also known as NPH insulin. So this is considered as the first choice in terms of long-acting insulin during the pregnancy. So consider continuing treatment with long-acting insulin analogs like insulin detemmer or insulin glargine for women with diabetes who have established blood glucose on these long-acting. Like if patient is using long-acting insulin in the form of insulin detemmer or insulin glargine and her blood glucose level is very good control on these long-acting insulin, she can go with that. There is no need to change to isoflurane insulin. Okay, but if you are given the choice that you are deciding or the endocrinologist is deciding to start the long-acting insulin to the patient, then what should be your first choice? You can answer that the first choice should be isoflurane insulin. Okay, but if you're asked in term of that she is already having using the long-acting insulin and the glucose is control on it, so should you change it? The answer should be no. She can continue the same long-acting insulin analogs. Okay, dear students? Okay, G, the next, what other important medication you should review, and you can stop those medication before conception or as soon as the pregnancy is confirmed. The number one is you have to stop. This is very important FCPS and MRCOG exam question. Note down it please, that you have to stop angiotensin converting enzyme inhibitors and angiotensin receptor antagonist, okay, or angiotensin receptor blockers. We used to call it ARB. So before conception or as soon as the pregnancy is confirmed, you have to stop these two BP, blood pressure controlling medication of the patient, and you have to stop another drug. This is important FCPS question, that you have to stop the statin before pregnancy or as soon as the pregnancy is confirmed. Okay, so please note these three drugs are written in your guidelines and you have to remember that what drugs need to be stopped. Okay. The next one is retinal assessment before pregnancy. As we study in the initial first two slides, that we have to emphasize on the importance of the retinal assessment before and during pregnancy. I told you that retinal assessment is done 2 times, before pregnancy and during pregnancy. You can learn that we have got 2 eyes, so for eyes we have got 2-time assessment. Before pregnancy, if patient came to you in pre-pregnancy counseling section, and if patient came to you during pregnancy, you have to do that again. Okay, so offer retinal assessment at the first appointment unless they have had a retinal assessment in the last 6 months. So please note this. If you are giving EMQ, or if you are given SBA by your RCOG, by your CPSP, that the patient had retinal assessment in the last 6 months, would you like to go again with the retinal assessment now, at which time she has came to you? The answer would be no. But if they are telling you that the patient had retinal assessment 1 year back, then now, as soon as the patient has a first contact with you, you are going to have retinal assessment. Please note, this is very important. This question was also in your Konji book. So this is important question, that how you are going to do the retinal assessment. So note this point. And the last but not the least slide of pre-pregnancy counseling is that renal assessment before pregnancy. I told you that kidney assessment is done only before pregnancy, not during the pregnancy. So you have to offer women with diabetes renal assessment before stopping the contraception. Okay, so consider referring the woman. What is written here? Referring the woman with diabetes to a nephrologist before stopping contraception. If so, you have got 3 conditions. If any one of these conditions is present, please remember, you have to answer in your exam that we are going to refer this woman to nephrologist. Okay, so what are these 3 conditions? One is, if patient's serum creatinine is 120 micromole. Please note down the units as well. In MRCOG exam, sometimes the RCOG used to confuse you by changing the units as well. So not only the number you have to remember, you have to remember the unit as well, that it is 120 micromole per liter or more. Please note it is 120 micromole or equal. Okay, so if you are given the range of serum creatinine, that patient has got 121, 122 or 130, what you are going to do with this patient? So your answer would be that we are going to refer this patient to the nephrologist. Okay, next, see, this is written here, or. I am usually emphasizing on these short things because these things are going to confuse you in your exam if you are not getting concentration on these points. That sometimes they can give you 120 and the urine albumin ratio. So this is not and, this is or. Please note it. The second condition is the urinary albumin creatinine ratio. So what is that ratio? If that ratio is more than 30, then you have to refer that patient to the nephrologist. Okay, so note, this is more than 30. This is not equal to 30. Please note, this is only more than 30. This is not equal to 30. If you are given 31, 32 milligram per millimole, then you are going to refer this patient to the nephrologist. Okay, the next, again it is written here, or. The third and the last condition which you are going to see and then refer the patient to the nephrologist is the estimated GFR is less than. Please note, it is less than, not equal to 45. If it is less than 45 ml per minute per 1.73 meter square, you are going to refer this patient to the nephrologist again. Okay, so note these 3 points. If any one of these 3 points is given to you, that either the serum cret or albumin creatinine ratio or estimated glomerular filtration rate, and the range is written in front of you, you have to learn the ranges, the number and the units as well. And if the given question is outside these values, then you're going to refer the patient to the nephrologist. So these things are very important in terms of pre-pregnancy counseling, that what you have to give the target blood glucose level to the patient, you have to give the target HbA1c level to the patient, you should know how and when the retinal assessment should be done, and you should know renal assessment is done when, and if anything comes among these three conditions and outside the range of these three, serum cret, albumin creatinine ratio, estimated GFR, then you have to refer the patient to the nephrologist. These are very important questions of your pre-pregnancy counseling section. So I hope I got a little bit summary to you in the end as well, and you are going to study it, and you need to write down the important points. And if patient from now onwards, I hope that if any patient came to you in pre-pregnancy counseling, either in exam or either in your clinic or hospital, you are going to manage, you are going to counsel that patient on in term of these important points. So I am going to I am coming with the next gestational diabetes topic. So inshallah, I hope that soon I am bringing that to you. And till then, your mentor Dr. Asma Ali is saying bye to you. Allah Hafiz. Assalamu alaikum.